Good morning, all of you. Today I'm going to start a new topic that is Unit 2 of Clinical Refraction. And today we will talk about visual acuity. Now, what is visual acuity? Let me start with the basic thing of vision. Whatever we can see properly is normally known as vision. This is a layman term. This is not a very scientific term. We will come across the scientific term. Before that, let me explain you it in a layman term. So whenever we can identify or we can choose or we can see whatever things are there, it can be a form sense, it can be a color sense, it can be object, we can identify certain things. It is normally known as vision. Suppose I can see certain things as red. So it is also a type of vision, but that is a different vision, which is color vision. Suppose I can identify a letter, that is resolution. That means I can identify certain letters. Suppose I can identify a face, that is form sense. That is that this person is that. That means I can recognize certain things. Or I can identify a dot in a white background, that is minimum visible. So these are the components and also types of vision. So there are various components and various visual types and various ways of measurement. So in this lecture, we will come across all those things. So let's get started. So the first of all thing, what we will learn in this today's topic is the definition of visual acuity. What is visual acuity? Why visual acuity is so much of important? Because not only visual acuity or vision is important, but where the implication of it is in optometry or in eye care related practice. Because vision is the most important thing which is used in our everyday life. And for optometrist, as you can know that optometrist means opto means vision and metrist means measurement. So our main thing is visual acuity measurement. So to understand that, first of all thing what we need to know is the definition of visual acuity. Next is to understand the components of visual acuity. So once we know what are the components are there, then we can also know how which visual acuity component is more important for measuring the visual acuity. Once we are done with that, then we will try to know different types of chart which is available. All types of vision cannot be measured in one chart, or there are different types of chart which are for different age groups, different types of patient, different types of people, different types of language literature knowledge people. All these types can be known by different visual acuity charts. So we need to know different types of charts. Next is to learn the retinal resolution and opto size. Until and unless we don't know understand what is retinal resolution and the opto size types, we will not be able to know the real reason of visual acuity, and that is very important. Next is to understand the Snellen fraction. Snellen chart is one of the most important chart where we will understand the Snellen fraction, how it is used and what are the main components. Next is to learn the limitation of Snellen chart. As I told you in first only, there are different types of chart available. And according to this chart, we will understand the limitations and we will also try to understand the total functioning of the chart as well as the limitations of the chart so that we can know what is the better chart which we can use for that age group of patients. So after that, we will try to learn the design and principle and clinical procedure of Logmar visual acuity chart. That will tell us what is the use of this Logmar chart or the log sinometric chart. So we can understand what is the Logmar chart and where the Logmar chart is used. And then we can understand different vision, near vision chart and the documentation of the results. So how to document it? In the last lecture, I told you, showed you near vision charts. Here we will try to understand different types of near vision charts, and also the documentation of the results is very important. Until and unless we don't understand the documentation of the results, we will not be able to understand the different types of visual near vision chart and the uses of the near vision chart. We will not at all be able to understand. So first of all thing is the visual acuity is the measure of the resolution capacity of the eye. Okay. So first of all thing, what is visual acuity? If I tell you to tell it in a layman term, I told you in layman term that anything which we can see or Understand, that is, we can call it a vision. But clinically, if we want to explain it, it will be, we can say that visual acuity is a measure of resolution capacity, means to understand what is the letter, how is the letter is there. Visual acuity is defined as the smallest retinal image that can be appreciated, and it is measured by smallest object that can be seen at a certain distance. So visual acuity can be defined as the smallest retinal image, means the smallest image that can be appreciated, and it is measured by the smallest object that can be seen at certain distance. So, to make it very easy, you can call it that visual acuity is the smallest retinal image that can be appreciated, means the smallest size of the letter which can be seen, appreciated, and measured by the smallest object that can be seen at certain distance. So this is known, basically known as visual acuity. So what is minimum visible? Ability to see something clearly from a background is normally known as minimum visible. So what is minimum separable? Minimum separable means ability to see a group of points or lines are separated and distinct. It is known as minimum separable. So what is minimum visible? Ability to see something clearly from a background. In the background, if you can see something very clearly, like here you can see the T very clearly. So this background is very important. That is known as minimum visible. So minimum visible is very much required. Otherwise, you will not be able to understand which one is the proper component of the letter. So to understand that, you need to understand from a background. So that means the background is also important. So the ability to do something see clearly from a background is normally known as minimum visible. Minimum separable. Suppose two letters are there back to back. Here you can see O and Y, you can understand clearly. Here you can see HBU, you can see, but in the last, if it all get crowded, you will not be able to see. So whenever you can see separate and distinct from a group of letters, a single letter you can identify and you can see properly, it is basically known as minimum separable. Otherwise, it is known as minimum visible. Okay, so two components we already covered. One is minimum visible, another is minimum separable. Last is minimum legible, whether we can read the smallest letter, able to identify a particular letter or a symbol from a group of letters, or smallest letter is known as minimum legible. So whenever we can read or understand the smallest letter from a group of letters, then only we can call it minimum legible. So now we will come across what is the clinical use of visual acuity. Until and unless till now we have known the component of visual acuity. So what are the components in this chart? What are the components are there by which we can identify it as a single chart, or what are the components is required to make a chart, that we know it. But now we will know what are the uses of this clinical chart. So the first of all uses is to measure or quantify the resolution capacity of the eye. Means we will try to measure or quantify. We will try to measure and try to believe how much we can see. Okay. Resolving capacity means how much is the power of our eye to see an object. That is called as visual acuity. Next is visual acuity can reflect the general health and functioning of the eye. That means if visual acuity is good, that means it is considered that general health and functioning of the eye is also good. So if the visual acuity of the patient is good, then we can say that general health means our eye is also functioning properly. If our eye is functioning properly, then our entire visual system is functioning properly. So visual acuity is a very important indicator for giving us or letting us know that our eye is very good. Otherwise, we will be able to know that there is certain problem in our eyes which is causing the visual acuity of not becoming a normal. Next, helps to prescribe aid. Suppose the visual acuity is not okay. So we understand that there is a problem. And while we know that there is a problem, we will do the detailed analysis. Once we do the detailed analysis, we will can give or prescribe different visual aids to the patient. Once we give the different visual aids to the patient, we will able to understand which aid. Suppose the patient is having a myopia. myopia, we will give concave lenses. Suppose the patient is having hypermetropia, we will give convex lenses. Or patient is having an astigmatism, we will give you cylindrical lenses. So once we know the visual acuity, we can also do the further investigation. We can also find out what is the problem. And after finding out the problem, we can prescribe the aids. So visual acuity is a quick thing to understand which component we can use and which optical use instruments we need to use and which one we can use to do the correction. Next is it also helps to monitor the eye health during treatment. Now we also have to find out sorry, to monitor the eye health during the treatment. Until and unless we don't monitor, suppose before the cataract surgery we are checking the vision, we can see the vision is very poor. After the cataract surgery, just before the surgery, we have to check whether there is little bit of improvement or not. We can see a little bit of improvement, so the cataract surgery was successful. After 1 week, we will see whether the full visual acuity has come or not. If the full visual acuity has come up, then we can say that full treatment of the patient is completed. Then only we can say that the treatment is successful. That means the cataract surgery is successful. This is how monitor of eye health occurs. And it is a most important thing, it is used for legal purposes. Legal purposes means for giving driving license, job fitness, blindness certificate, all these things visual acuity is very much uses. Because if you don't have proper eyes, you cannot get proper driving license. You're driving, you are not eligible to drive. If you don't have a proper job fitness certificate, means in various jobs you need very good vision. If you don't have proper vision, your job fitness certificate, job fitness, you are not fit for a job, so you will not get a job. There are a lot of color companies or there are a lot of acrylic companies where they check the color vision of the patient. Okay, so vision is very important, and also blindness certificate. If you are blind, you need certificate so that people can tell or you can get certain facilities from the government. Now, what are the different modes of checking visual acuity? This is very important. If we don't know this, then it will become very problem and it will cause a lot of problem for further investigation also. Mostly there are two types. First one is the distance chart. And in distance, we have got two types of visual acuity. One is the Snellen chart, another is the Logmark chart. And the second one is the near chart. Near chart also, as I was discussing in the trial frame chapter, that there are different types of near chart like Snellen chart, Logmark chart, M notation, N notation, J notation. So these type of charts can be used for distance and near. On the age-wise difference, we can divide it into three parts. One is the adult, where we will use it in the literates and illiterates. Children, where we can use it in letters, pictures, and numbers. And also for infants, where we will use it for the infants to check whether the charts are available or not. So here you can see different types of distance chart are there, where we can call Logmark chart, Snellen number chart, Snellen E chart, optokinetic drums chart for children. So there are, as I told you in the start only, that there are different age group, we can use different chart. For different eye condition, we have got different types of chart. In certain eye disease where we can use Snellen chart, but we cannot use Logmark chart. There will be certain where we have to use Logmark chart where Snellen chart cannot be used. There will be some patients where patients who cannot read and write, we have to use Snellen E chart, or we have to use optokinetic nystagmus drum chart to understand where the infants are. So for picture chart, we have to identify the pictures and other thing. So we have to know which chart can be used and which chart is should be used and which chart is indication for which patient. Then and there we will be able to understand or prescribe certain chart for the patient. Now, before going into the principles of chart and other thing, we first of all think we should know about the visual angle. Now, what is a visual angle? Visual angle is defined as an angle subtended by an object at the nodal point. Suppose this is my nodal point and this is my object. The angle which is the nodal in the angle which will be formed at the nodal point of the eye is normally known as visual angle. And this angle will be used by the patient to understand the letter which is over there. So visual angle is defined as the angle subtended by an object at the nodal point of the eye. So this angle is normally known as visual angle. Suppose you can see here when the object is at far, the nodal angle is small. When the object is nearby, the nodal angle will be more. You can see the first the visual angle was less. As we are bringing the object closer, same object, you can see the nodal angle is very high. Okay. So if the object is closer to the eye, the visual angle will be larger. Hence we see the objects bigger. Now let's come to the first chart of the distance visual acuity, which is normally known as Snellen Visual Acuity Chart. It is designed by Harman Snellen in 1862 in the 19th century. Using later chart, we are measuring the resolution capacity of the retina. Means how much our retina are able to see. Letters or objects in visual acuity charts are normally known as optotypes. Optotypes means letters, which we normally use. The size of the optotypes are especially calculated for each chart. So according to the Snellen, each limbs, you can see each limbs are divided into 5 components, 1, 2, 3, 4 and 5. And here also there is 5 things, and each limb makes the angle of 1 degree. So this 1 degree, and the total letter will make an angle at the nodal point of 5 degree. So each optotype angle of the arc will cause an angle of 1 degree, and the whole optotype should make an angle of 5 degree, through which we can understand that this is a Snellen chart. Otherwise, it will cause a lot of problem. So the value of tan 5, as we all know, is 0.00145. If the chart to eye distance is 6 meter, then the height of the smallest letter chart will be 6 by 6 letter. In the chart would be 6 into 0.005. So the height will be 0.873 centimeter, which is 8.73 mm. So this is how we can calculate all the letters of the Snellen chart. And the normal distance of the calculation distance from where we do, we all know is 6 meter, because 6 meter is considered as optical infinity. How we can now calculate the letter size? So from 6 meter distance, if we measure the first letter, we will all know, explain it as 6 by 60. If from 6 meter distance, if we can read the second line, it will be known as 6 by 36. If it is 6 by 24, where we can read the third letter, it is known as 6 by 24. From the fourth letter, it is 6 by 18. Third letter, 6 by 12. Last letter, 6 by 9. And the last letter is 6 by 6. So till the last letter, where we can read the last letter, is known as 6 by 6. How to record it? Testing distance, first of all thing we will do, which is 6 meter. Entire distance at which the entire letter subtends an arc of 5 degree. When the letter will subtend an angle of 5 degree of angle of the arc, we will normally measure the angle as suppose 6 is 6 by 60. Suppose the testing distance is 6 meters, 6 meter, and the distance at which the letter subtend a 5 degree arc is 60. So it will considered as 60. Usually the distance chart is tested at 6 meter. Why 6 meter? Because 6 meter is known as optical infinity. No clinical significant accommodation is active at 6 meter distance. So that is the reason we consider as 6 meter distance as the normal test distance for measuring the visual acuity. Now, what are the limitations of Snellen chart? This is a very important thing, because Snellen chart is widely used, but till now Snellen chart is also used. But Snellen chart has got its drawbacks, and we should know where we cannot use the Snellen chart, because if we are using for all the patients, then there can be a not a very good visual acuity results will come. So we have to understand that. Okay. So the variable size progression, varying nature of the tasks, difficult to apply in patients with significant visual impairment, unequal number of letters per line, and unequal number of letters per line also we have to see. Suppose a single letter, there is T, in the double letter VH, in the third letter XUA. So the variable of size. In one letter, letter you can, one line you can see one letter. In two line, second line you can see two letters. In third line you can see three letters. So equal number of letters is not there in Snellen chart. That is the biggest drawback of the Snellen chart. Unequal number of letters per line is there. So to counter this drawback, a new chart has come, which is normally known as logmar chart, which is known as design principle by Bailey and Lowy. In 1980, they made this chart, and the size is the only significant variable when changing from one size level to the next. Okay, so logarithmic, what are the features of logmar chart? Logarithmic size progression from one size to the next, same number of letters at each level, five optotypes. So each letter has got five optotypes and same number of letters is there, five in each. I will show you the chart in the next slide. Spacing between the letter and the row are proportional. In Snellen, there was no spacing of the letter and row was proportional, but in Logmar, it is proportional. Similar average legibility of for the optotypes at each size level. Each size level, the legibility for the optotype is same. Suppose the same for uh, each size level, it is same. Okay, now this is thing. Each size progression, each letter has got 0.1 log units. Each line 0.1, each letter 0.02. So 0.02 into 5 is 0.01. So each successive step represents a change in the by the ratio, that is 1.25 is to 1. And that is how each letter is 1. You can see here 1, zero point 0.9, 0.8, 0.7, 0.6, 0.5, and 0.0 is considered as 6 by 6. So this is how logmar chart actually works. Solan and British letters are widely used today. Solan letters cost 10 letters, that is C, D, H, K, N, O, R, S, V, Z. So these are the Solan letters, 10 letters, which are used for legibility for logmar chart, and or we can use British letters D, E, F, N, H, P, R, U, V, Z. So these are British letters, we 10 letters. Within this group, we have to similar legibility. Now how these things are done, you can see here the spacing height of this and this is same, this spacing and this height is same. So this is how we make the logmar chart, so that the logmar chart are equally distributed. You can see the size progression is there, so that's why the line has gone equally down. It is not like Snellen that you have two, one in the first, then 2, 3, 4, 5, and last it is crowded. So you can see the crowding phenomena is not there. In the last, you can see 0.0. If anybody can read it from the prescribed distance of 4 feet, you can see 40 meters, then the patient will able to read. It helps to reduce the crowding of the optotype. So 5 letters line each is 0.02 logmar. So plus 1.1 minus total count into logmar LV by logmar count. Total number of optotypes correctly identified 0.02 into the logmar count into 5. Suppose in one letter, patient has written 1. Okay. So in the next letter, the patient is not able to read 3. So 0.02 into 3 minus this 0.9. So or plus this 0.9 or minus the 1 over this. So when we are putting 1 minus these three things, we are getting the power absolutely correct. So this is how we get the logbar chart. Near vision chart is tested. Now the last component we are coming across, that is the near vision chart, which is very important. I think logmar calculation we can take another session for the calculation part, because calculation is little bit difficult. We can do it in the practical classes basically, because logmar chart you need little bit of calculation. If one is there, either we can add this letter which we have added, we can subtract it from this line, or the letters which we have not been able to read, we can add it with this line. Okay, so suppose this is 1, okay, and these two patient cannot read, and these three the patient can read. So how we will do? These three the patient can read, so we can add it with these two, so 0.96, or we can use these two, 0.02 into 4, we can deduct it from here, so it will come again 0.96. So both the cases it will come 96, but in two ways we can calculate the logmar value. Is that clear to all of you? Okay. So Snellen is comparatively easy. So if anybody cannot read Snellen chart, suppose 6 by 36, you cannot read 1. So you will put 6 by 36 minus 1, or 6 by 24, a patient cannot read 1. So you can write 6 by 24 minus 1, but that's not accurate. But logmar is little bit complicated, but it's more accurate. Especially logmar chart is used for patients with retinal problem, diabetic retinopathy, macular degeneration, all these patients, especially low vision patients, it is very much used. It can be used to much perfection, because logmar chart is ultimate chart which can give you an error free. But again, you need doctors or optometrists who knew exactly how to write the chart, how to interpret the chart. Otherwise, it will create a lot of problem. Okay, so that expertise is required while using the logmar chart. Otherwise, logmar chart will be good, but it can cause a lot of problem. So as I told you, so these are the Snellen. So now we will come across near visual acuity chart. As I told you, near visual acuity chart normally we use it at a one hand arm distance or one arm distance, that is 35 to 40 centimeter. Charts are different from distance chart. It is not the same chart which we use. It's a reduced chart. So we called it reduced Snellen or reduced logmar or M notation, N notation. There are different types of chart, as you can see in the example. N chart is there, M chart is there, reduced chart is there, Jagger's chart is there, and continuous chart are commonly used to check near vision. Continuous chart means the patient has to read. So whenever the patient has to read, it checks the accommodation, it checks the near point of accommodation, and it also checks the near vision. So especially near visual acuity chart is normally checked with presbyopic patient. So with this chart, if we check the presbyopic patient, then only we will able to understand where the problem is. If the patient is not able to read, we can understand there can be accommodative problem, there can be physiologic problem, that is presbyopia. So we need to give correction accordingly. Now, how to write down this chart very nicely? So near vision testing distance, first of all thing we have to write. We have to write down the name of the chart, and we have also have to write down the aided, whether or unaided. With glasses the patient is reading or without glass. So normally for distance visual acuity we write VN. For near visual acuity we write NVN. We give OD and OS. Near and visually N6 and N12 at the rate 33 centimeter with N chart. So we can easily understand whether it's a distance chart or near chart properly. Okay. So this comes our end of visual acuity lecture, which we have discussed what are the components we have used. So different types of distance chart. As you can see, the most common chart, that is the Snellen chart, which we have used. Next is we have used the logmar chart, which is much complicated but much accurate. Most of the hospitals and especially low vision clinic and specialty optometry practice, they are using this logmar chart, and the calculation of the chart is, although it's difficult, but it's very much required, because these calculations and this value actually tells us the exact condition, how much the vision, especially with the low vision patient whose vision is very less, they can be easily evaluated, or they can be evaluated very correctly or very well with this logmar chart. And last but not the least is the near vision chart. Without the near vision chart, we will not be able to understand how much is the problem, where is the problem. And with the near vision chart, not only the presbyopic patient, but also we can check the accommodative problem, and we can give different accommodative therapies also with the help of this chart. So this chart actually tells us where the problem is with the near vision, whether it's an accommodative problem or whether it's a presbyopic problem, which is a physiologic problem. This comes to the end of this series of lecture, unit 2, that is presbyopia. Okay.